and Cuba are changing the world's conception of healthcare. Thank you so much for joining us. It's wonderful to see such a packed auditorium, just like we'd hoped. I'd like to take a moment to express our sincere thanks to all who have helped to make this event happen tonight, especially to all of my co-facilitators in Radical Public Health. We'd also like to thank all of our co-sponsors, including the Global Health Student Interest Group and Alison, the Public Health Students Association, who provided for the reception that will follow the lecture, Emergency USA from the School of Nursing, and the Chicago Committee to Free the Cuban 5. Without the cooperative leadership of all these groups, as well as the support of our faculty advisor and two very generous individual donors, tonight's event would not have been possible. Of course, we are also grateful to Steve Brower for coming to share his experience with us, and Peter Orris, who will introduce tonight's subject, and Steve Brower in just a moment. We are really excited to bring this lecture to you today. So this summer, when we heard that Steve Brower would be making his way through Chicago, Radical Public Health was nothing more than a few current and former students of UIC's School of Public Health. We had just begun to hold discussion meetings in bars where we would take critical perspectives on public health issues and consider more radical solutions. Eventually, we determined as a group that our goals are to broaden the discussion to include the wider School of Public Health community, to provide a forum for radical perspectives, and in doing so, to normalize radical perspectives in learning, research, and practice. So this lecture provided a perfect opportunity for us to engage the broader community in conversation. Now, after just a few months, Radical Public Health is a vibrant community made up of students, faculty, staff, alumni, and practitioners from a variety of disciplines across the campus and across the city. We even have fans across the globe. And right here we have a packed auditorium eager to hear tonight's lecture. So moving right along, we will soon hear from Dr. Orris and then Mr. Brower. Following the lecture, we will have a question and answer session, and then we will move down the hall for our reception in the lounge by the front entrance. You're all welcome to join us next Monday, also for a discussion meeting that we will hold here at the School of Public Health at 6 p.m. And in that meeting, we will consider the impacts of mass incarceration, the drug war, and the prison industrial complex on public health. So, without further ado, I'm pleased to introduce to you Dr. Peter Orris, a professor here at the School of Public Health and Chief of Service for Occupational and Environmental Medicine at the University of Illinois Hospital and Health Science System. Dr. Orris has been researching, teaching, and writing about the Cuban health system for nearly 50 years. He has published a number of articles and book chapters on Cuban healthcare and occupational and environmental health in Cuba and the US. Dr. Orris also holds professorships at Northwestern and Rush medical schools, and he has served as an advisor to the World Health Organization, the Pan American Health Organization, as well as federal, state, and local governments, and environmental organizations and labor unions. Additionally, Dr. Orris will be leading the American Public Health Association's delegation to Cuba in just a few weeks. Dr. Orris will now provide a context for tonight's subject and then present Mr. Brower. Again, thank you everyone so much for coming. We look forward to debriefing with you at the reception.
Wow, what a crowd. This is really exciting. Radical Public Health here at UIC. Student group. There are several people in the audience that have been waiting for this for quite some time. So we're tickled pink, as they say, or tickled red, or whatever. My tasks are very brief. Since it's a public health group, I'm here to give you a little structure of the Cuban health system, and then turn it over for the more global perspective that you will be hearing this evening. Let me put in a couple of advertisements. You mentioned the trip to that APHA is taking to Cuba in December. That one's closed already, but there is another one that's going in February that's open from the School of Public Health here from our program, the Health in the Arts program, which is a program concerned about health of artists, both performing and graphics artists. And this will be their third trip to Cuba over the last several years, going in February. Anybody interested? David Hinkamp is leading it, or you reach me or any of the rest of us over here in the Occupational Environmental Health Program at UIC. Now, the question is, somebody going to tell me how to find what they just put on there? There's a lot of time. They asked me if I'd signed up on for this on Facebook, and I said, what? That's why I'm wearing my suit and all of this, 'cause I figured that's my slot for the evening. Though close to 50 years was a low blow, I must say. Okay, these are some stolen slides from a colleague in Havana, and they're a couple of years old, but the structure we're talking about is the same. The Cubans in 1963, after studying healthcare systems around the world, including Chile, Eastern Europe, England, Canada, and other areas, decided that they would develop a national health system, that they would develop one that was really new conceptually. They wanted to integrate primary care and curative medicine with preventive medicine and put them together in one structure. And they did so based on primarily the Czech model originally. This was a model for universal health care, accessible to the entire population, which was no mean trick for Cuba at that time, free for all citizens, no sexual differentiation, no religious differences, and no racial differences, all important in Cuba at that time, and without differences of access due to place, because most of the Cuban healthcare at the time was based in only the big cities. About 50% of the population reached any of it. Most people had healthcare only for half a year or so when they were working on sugar plantations and others. So this was really a revolutionary, obviously, approach to the system in Cuba itself. So revolutionary that the private practitioners, physicians that were practicing in Cuba at the time, 2/3, well actually 50% of them fled the country for the richer climes of Miami, and 2/3 of the medical school teachers left as well. Caused really some significant traumas and stresses on what they wanted to do initially. They also immediately, despite being resource poor, integrated the concept of internationalism and their obligations to other countries, poor countries around the world as well. This, of course, as you are aware, earned them the enmity of the U.S., and that enmity got considerably worse over the next period of years. But let me stick with the healthcare system. And I'm pushing the wrong buttons. There we go. The system itself is based on, and I'm describing the system that is there today. One of the extraordinary aspects of the Cuban leadership and the Cuban political development itself over the last period of years is not so much its ability to not make mistakes, but its ability to make mistakes and learn from the mistakes. And as you know, many countries around the world of whatever political stripe make a whole lot of mistakes and then pretend they never made them to begin with and rewrite history on the way. Cuba tends not to do that, and tends not to do that really standing out. So the Cuban healthcare system itself changed along the way on a variety of occasions, and stimulated frequently by the involvement of the citizens and the involvement of the political structure within the healthcare system itself. The system today is based on the family doctor office,
which is staffed by a primary care physician, nurse, public health nurse, primary care nurse, and they are based in a small neighborhood, usually only a few blocks in size, that in the mornings people practice in their own office, people come and patients come to them. In the afternoon, the doctor and the nurse and others reach out to people who have chronic diseases and in the community themselves and visit their patients in their homes. These units then are aggregated into basic working groups. There's some education that goes on there, some sharing of clinical tasks, etc. These basic working groups then are pulled together into the area of health. At the level of the area of health, you have the polyclinics. Polyclinics in Cuba are somewhat different than polyclinics we've seen in other countries around the world, because people had a choice of whether or not to go to one polyclinic or another polyclinic. Most people chose their own neighborhoods with the physicians in their neighborhoods, but that was not rigidly enforced. These polyclinics then were coordinated now, or are coordinated now, at the municipal level, where there usually is a hospital, a general hospital, maybe a pediatric hospital if you're in Havana, and maybe even a more specialized hospital in one way or another in some of the cities, but a general hospital in less developed areas. These hospitals then are coordinated at the provincial level by the Provincial Health Authority and the Ministry of Public Health over that. Now, one of the things they discovered, that when you budgeted along that route, that sounds like a great route, right? The whole country is coordinated, everything's planned out, they do it at a national level, it's a small island, only 11 million people at that time, or even less. And so it all sounded great, but it turned out that if you budget at the national level and you apply everything down through the structure itself, you build some rigidities into the structure, you build some inability to respond to local community demands and others. So they decided some years later they were going to budget through their developed now legislative system, municipal popular power assemblies. And so the budget is now done at a municipal level. There is one as well at the provincial level, and at the national level, the national elected leadership as well impact on the overall state budget. It's obviously a much more complex process that goes on here, but it provides some of the internal abilities for different interests and different approaches to be worked out, which was one of the things that they discovered as this went along. So that's basically your structure for the system as a whole. At the national level, you have institutes, you have levels of technological treatment that rivals the US in many ways. And in fact, some years ago, they set up medical tourism there, and they constructed some hospitals directly so that if you were in Latin America and you were sick and you had an esoteric disease, you didn't have to come to Mayo Clinic or Rockefeller Institute in New York. You go to Havana and you're in a huge building looking out on the Caribbean from the other end, getting the same kinds of care for far less money. They described these medical care facilities. They built many. And I won't go through it, but the whole country is covered by both primary and tertiary care facilities. They had to not only train doctors, but they had to train all other staff, all other public health workers in this process because, as I said, the country was really did not have adequate coverage initially. They also, as a matter of public policy, decided that they were going to train many more physicians than they in fact needed out there in the structure of the country as they and the healthcare system as they had put together, and they sent physicians abroad. They concluded they were not going to compete with the United States and did not want to compete with the United States militarily or in a variety of other ways, they would compete with the United States in the ability of sending their humanitarian healthcare workers throughout the world. They do have them now throughout the world. And some of these bring in needed revenue to Cuba itself, which continues to face the blockade from the United States. But many of the others are donated for the benefit of people in the country, and we're going to hear some of that experience in Venezuela later on. In addition, they decided they weren't just going to send their people abroad. They wanted to bring the countries that they were working in solidarity with, they wanted to bring the healthcare professionals from those countries to Cuba itself for training. They did so, and then they wanted those to go back to their own countries and set up medical schools and public health schools and train health workers in their countries themselves. As part of the process of creating a medical school for foreign students, some years ago, they decided that they would train actually at the stimulus of the Congressional Black Caucus. They decided that they would, in this country, that they would train physicians in this country from poor communities who pledged to go back and work in those communities who did not have enough money to go to medical school here on their own. And they have trained many, and there are some in the audience who train, and I'm sure will be available for discussions. But in the Elam Medical School, there has been a class of Americans training there for 10 years? 8 years, something more or less, as it goes by.
98.
98? Okay, so 14 years, not bad. All right, and there were only scattering students prior to that. So that's all I'm really going to say about Cuba to set the scene. One thing I want to make sure that we mention here, though, is the importance of the Cuban Five. This was a topic that was not raised in polite company in this country for quite some time, because these were 5 Cubans who were sent to the U.S. by the Cuban government to keep tabs on the refugee community in South Florida, etc., because that community, as you know, had self-organized and organized with the support of the Central Intelligence Agency to continue to take aggressive action against Cuba over a period of years. And the Cubans had lost 4,000 some odd civilians to this campaign that was being orchestrated sub rosa within this country, but by Cubans themselves. The U.S. government said these were intelligence agents sent from Cuba to spy on the U.S. and has kept them locked up for years now, and has not been open to any kind of negotiations about repatriating them or any kind of discussion about family visits and others, because obviously their families are in Havana and cannot come to the States with any regularity. Having said all of that, these folks are still in jail. The Cuban government has steadfastly maintained that they were sent here to spy on the Cuban who were taking aggressive action against the Cubans against the island of Cuba itself. And I don't want to leave a discussion of this without the importance of the fact that these folks are still in jail and need to be discussed and need to be freed and repatriated to their country. Having said all of that, let me say something about our speaker tonight, and we really appreciate the fact that you put Chicago on your agenda and on your schedule. Steve Brower is an author of a number of books about economic inequality. Many of these have been written for the general reader and feature illustrations drawn by the author and other artists. By the way, this is a edited version of this, because you want to hear him, you don't want to hear me talking about him. So I had to take out a bunch of the different books, etc. I apologize for this. The first, Robbing Us Blind, The Return of the Bush Gang, which came out in 2003, not the first book, but the most recent one. Sharing the Pie, A Citizen's Guide to Wealth and Power in the United States, 1998. Conquest and Capitalism, 1492 to 1992. Came out in 1992, appropriately enough. He's the co-author of Exporting the American Gospel, Global Christian Fundamentalism. In addition, he works with his hands as well, designing and organizing housing cooperatives, building the houses, and has put together and was in leadership of a worker-owned construction business as well, and directed a nonprofit community housing program in Pennsylvania, if I'm not mistaken. Yes? No?
In Ithaca, New York.
Ithaca, New York. All right, never been somewhere.
I live in Pennsylvania now.
There we go. In 2007 and 2008, he lived in a small village in the mountains of western Venezuela, and wrote about the participation of his neighbors in the Bolivarian revolution. At the time, he posted more than 30 essays with photographs, and the importance here is that they are still available on the web, on his blog, which I hope he'll tell us how to reach, or maybe even show us on here. During his stay, the author became fascinated with the comprehensive new public health system, Barrio Adentro, that Venezuela has created with the help of Cuban health professionals. He visited primary care facilities and diagnostic centers, went to classes with students who now provide free medical care throughout the country. This experience was the genesis of this recent book that he is here to talk about today, Revolutionary Doctors, How Venezuela and Cuba Are Changing the World's Conception of Health Care. And he lives with his family in Pennsylvania. And we welcome him and thank you very much. Please, over to you.
Great job, Alison.
I did run away.
Good evening, everyone. It's a pleasure to be here. I guess I have to find my slideshow now. I've been asked to make a few quick announcements before we get going. The Cuban Five, I'm glad you spoke about the Cuban Five, Dr. Orris, and everyone should know about them and should make other people aware of them, because I think most Americans still are not aware of the Cuban Five. There's some free postcards down there. At the top of the postcard it says, "Can you be imprisoned in the US for opposing terrorism?" Yes, if you oppose terrorism in Miami. So you can pick them up for free there, and I think there's some free films there. Feel free to buy a copy of Revolutionary Doctors. Makes a great Christmas present. They're on that table and a table outside. And the other thing is there is a little plastic bucket that's going to circulate. You may not know it, but before Hurricane Sandy hit the United States, it caused a lot of damage in the Caribbean. It went through the eastern end of Cuba and really devastated a significant number of houses around Santiago. So there is a group, Cuban American Friendship Group, that's collecting money to send for rebuilding houses that have been destroyed. And I guess some matching funds are being provided for whatever gets collected. So that's just going to... What's that?
Check?
You would have to ask Stan how to make out the check. He's right next to you there. All right. Okay. I think that was it. Oh, no, it wasn't. We also have someone here tonight from the Venezuelan consulate here in Chicago. Rixio Barrios is going to stand up right in the middle. And he just wanted to let you know, if you have any questions you'd like to ask him or know more about the consulate here in Chicago, speak to him afterwards. He'll be hanging around too. Okay, let me pull up the slideshow and we'll get rolling. Okay. Now, as Dr. Orris mentioned in the introduction, I went to Venezuela a few times before 2007, 2008. 2007, 2008, I went to live in the countryside. And it was after I had made previous trips, shorter trips, and I'd become aware from those early trips that the Bolivarian Revolution was a real revolution. There was a social transformation taking place on a very large scale in very interesting circumstances, I mean, kind of unique. And I decided I would go back. But my first trip in 2004, when I actually got to meet President Chavez for a little bit and go to conferences in Caracas, I went because I finished one of these books, Robbing Us Blind. As Dr. Orris said, I've been writing about social and economic inequality in the US for a long time. So I have 4 books that have dealt with that. And every 5 years it gets worse. And people have been asking me ever since Occupy Wall Street, where's the new book? You know, we want to update. And I suppose I'll be starting that in the next year or two. But in 2004, Bush had been reelected, and I'd been speaking about what had been happening to our country all that year. And, you know, that stuff has to get talked about and written about, but it's also kind of depressing after a while, you know. I didn't really feel like writing my next book about that. In my books on the US political economy, I'd always included a chapter on healthcare in the United States, often drawing from the research of doctors Woolhandler and Himmelstein from Harvard and their great work on exactly where money comes and goes into the health system. And when I started, whenever the first chapter I was writing about healthcare, the US was spending twice as much money on its healthcare as Europe, Japan, Australia, Canada. You know, when you lump them together, it's twice as much. And that was true 20 years ago, and it's still true today in roughly these figures. And what we've done is create an awful lot of billionaires at the same time as we've created more and more people without any health insurance. And that means often without any health care in one of the richest countries on earth. So it's rather a staggering thing. So I'm going to start, actually, not with my stay in 2007, 2008, but with the few brief things that I was able to see on my first visit in 2004, when I visited several of the barrios of Caracas. And the barrio in Venezuela doesn't mean just neighborhood, it means a poor neighborhood. And in Caracas, that's the very steep hillsides and mountainsides around the city. And the housing often looks like this. This is the barrio of Antimano. And in 2004, the first of the Barrio Adentro walk-in clinics had been set up. This is a characteristic building. Today there's 6,700 some of these walk-in clinics spread around the entire country in almost every neighborhood of every municipality. In 2004, there were about 100 of these little buildings set up. Now there's about 3,500 or more of these, and then other kinds of structures and old buildings. Inside, there are very simple consulting offices, and things were so busy that particular day, the Cuban doctors had no time to talk with visiting gringos, and I talked with other people, particularly the health committee. And every neighborhood
that wanted a Cuban doctor or doctors to set up shop had to organize themselves in a health committee, usually 10 to 20 people, volunteers from the neighborhood, and they were responsible for a lot of things. In most cases, there was not a cute little building like this. In this building, the doctors lived in a tiny apartment on the second story. But for the most part, during this year of 2004, Cuban doctors had just arrived the year before, and they'd gone from a few hundred in Caracas. Within a year and a half, there were 10,000 Cuban physicians spread all over the country. And the reason they could do that quickly is that every health committee found them a place to live, a room in somebody's house, an abandoned storefront, and they provided them with food, and they led them around the neighborhood to introduce them to people, and in more violent neighborhoods, possibly to protect them if they weren't known to people. And they played a key role in setting up what has become now a very organized system. What impressed me the most was notes and actual graphs on the wall. These were computer printouts in a little office I went to later that was just the basement of a concrete building that was really pretty bleak. It was just handwritten notes. The neighborhood had helped the doctors collect information on the entire population of the neighborhood. So of 1,472 people, they had written down 53 children with asthma, 84 people with hypertension, etc. And then perhaps the most impressive, 150 malnourished people. And that meant the doctor had to see all those people and find out their sources of income and food and that sort of thing. This was what public health, primary health was all about, addressing these problems first. Well, these were neighborhood women. We walked over to this house that belonged to one of them. The government had provided them with big pots, gas burners, and they'd set up a community kitchen to feed those 150 people in the neighborhood. They served them 2 meals a day. People arrived from around the neighborhood with the Venezuelan equivalent of Tupperware. They filled it up with very well-balanced meals. I had a really delicious lunch on the food, and people were fed. I mean, perhaps the first step in making people healthy in a community. These women had no salary at all in those days. They simply got free food for their families, and they volunteered. Now they would have a salary, a modest salary that they could draw. This is a little Pentecostal church, but it was the biggest building in that neighborhood. It had a big worship room, and they gave it over to exercise classes and new educational missions in Venezuela. But this was a meeting of health committees from all over Antimino. So perhaps members of 40 or 50 health committees of various neighborhoods had all come together, and they were meeting with 4 sociology students from the Central University to talk about how to pull together the data they were getting from their individual neighborhoods and put it on the computer and have data for the whole barrio, which is 200,000 people. And so the students were doing that, and they were also giving tips to some of the people attending who were starting classes in the educational missions in computer science and how to use computers. The guy in the back with the Che shirt is actually one of the pastors at the church. So, one woman in the audience brought up the importance of sports trainers and sports activity and exercise classes, and I was new to Venezuela. I didn't even know this existed. But later that week, I went to Fiesta in another neighborhood, nighttime fiesta, and I happened to meet this guy. Actually, I met him because somebody beside me pulled a baseball card out of her pocket and said, "Aren't you Felipe Fernandez?" And he said, yeah. And she said, I met you in Cuba. Well, he was a pitcher. He was the relief pitcher for the Cuban national baseball team. While he was still playing, he went back to university, got his degree as a sports trainer. And at about age 40, he had just retired for a year or two. And what did he think was the next thing to do? Go live in somebody's spare room in a barrio of Caracas, getting paid $200 or $250 a month to work as a sports trainer in this barrio. He was not out getting million-dollar contracts to sell T-shirts as sports stars in our country might be doing. He was doing what seemed to come natural to many Cubans. And these were abuelitas, grandmothers, who were part of his aerobics class, because actually more of his duties were exercise classes for middle-aged and elderly people. He did coach baseball and basketball teams. And this was a young dentist, Jonel. I said to him when he maybe was the first person that mentioned to me that there were already 10,000 doctors in Venezuela. And he was showing me his Chinese dental chair he was quite proud of. He worked with a group of 20 in Havana, and they said to him, you want to go to Cuba? I mean, you want to go to Venezuela? Sure, you know, we can handle the practice here. And so off he went to Venezuela. He enjoyed being there. He said, you know, I came because I wanted to travel and see something of the world. I also grew up, you know, in the 1980s. My heroes were Cuban doctors who went to Africa, to Angola, and many other countries and served people. And I said, you know, so many doctors, this is like an army of doctors, un ejército de médicos. And he said, un ejército de paz, an army of peace. And that stuck with me. They have a name for themselves, the medical students who go to ELAM, who go to medical school in Venezuela, and they call themselves El Ejército de Batas Blancas. And batas blancas are just white jackets that doctors would wear. So an army in white jackets. With time, Barrio Adentro has grown to do much more than direct primary care, but primary care was first. That was the first step, and then you build on top of that. Secondary care was diagnostic centers, rehabilitation rooms, which are very well equipped for physical rehab, and high technology centers that would have MRIs and all kinds of other high quality testing equipment. So these are spread out around the country to serve a group of the primary care facilities. Well, in 2007, 2008, my travels to Venezuela had acquainted me with people in the mountains of the state of Lara. It's about 5 or 6 hours from Caracas to the west. And I asked them, what would you think about a gringo coming and living in the village of Monte Carmelo? Because I'd like to write a book about how campesino life is changing. How it's, you know, it's obvious to me that life is really changing for the poor and the campesinos and the working class in very major ways. And, you know, if I live here for a while, I can write about it. And they said, great, you can do it. So we rented a tiny little concrete block house with a tin roof and cold shower of nice water coming down from the cloud forest. This is really rugged terrain, and everybody in the village is a farmer, or was a farmer. These two are plowing with a horse because most places you can't plow with a tractor, it's too steep. You might be able to see they have Boston Red Sox caps on. They're actually my two sons. When they were 16 and 18, they worked full-time on the local organic farm that was up the mountain. So they got up at 5:30, climbed the mountain, and worked all day with a wonderful group of people while I took it easy and rode. They got that same field, they get 4 harvests a year out of that field, wonderfully fertilized with vermiculture, with worm compost. There's a typical house in the village, which is really just one paved road along a mountain ridge. And then people have their plots of 2, 3, 4, 5 acres of land. Some of the old houses, they're all mud and stick houses, the original houses. Some are crumbling. And the revolution is providing new houses. Lots of people have new houses either because they got an interest-free loan for the materials or because it was built for them at very low cost or no cost by the government. There's a program called Mercal that provides food at least 40% discounts from market prices. There are little Mercal shops, 15,000 of them all over the country, but also special events where a village like ours would have truckloads of food come in, and then the whole village got together and distributed the food to the classrooms of the elementary school, and it was purchased at these low prices by pretty much everybody in the area. Everybody was in on it because it's that kind of place. Here is, Dr. Orris mentioned my blog, Venezuela Notes. You can still find it online and look at some pictures and articles that I wrote. They're almost all old, but they're still pretty pertinent. And this picture is just one thing. There's so much misrepresentation of Venezuela in our media, and you may or may not know that. But it's a thriving democracy. It's not a dictatorship. And the most extraordinary part of it are the consejos comunales, community councils. It's a participatory democracy, very much like New England town meetings. I can't think of anything it's more like. In our town, at this particular meeting, about 50 of the 125 families had representatives at that meeting because important issues were coming up. And these 3 women were running the meeting. The one in the white hat is also chair of the banking committee, which is important because not only do they vote on important issues of self-government right there in the village, they have direct access to funds from the federal government, so that funds don't have to go through the state or municipality, but they can apply. If they have 15 houses to be built, they can apply directly, and they manage the funds, see that it gets built, and it's proven in most places to be very efficient. We had celebrations once in a while. That's the church on the left. People are dancing and celebrating the Day of the Seed because the village had established a seed bank for literally thousands of seeds that are used in local agriculture. And people have, lots and lots of people have their own collections, including these 5 girls. They had all their jars of seeds that they collected. And this brings to mind, before we launch into more about medical training in Venezuela, a quote from Che Guevara, 1961. He gave a talk on revolutionary medicine in Cuba, wondering about what the future might be. Now, I've quoted Che in this book here and there at the beginning of various chapters. One should not draw the impression that Che created the Cuban medical system, because he didn't. But he was a medical doctor before he became a guerrilla. And he said this in 1961. A few months ago, here in Havana, It happened that a group of newly graduated doctors did not want to go into the country's rural areas and demanded remuneration before they would agree to go. But what would have happened if instead of these boys, whose families generally were able to pay for their years of study, others of less fortunate means had just finished their schooling and were beginning the exercise of their profession? What would have occurred if 200 or 300 campesinos or campesinas had emerged, let us say by magic, from the university halls? What would have happened simply is that the campesinos would have run immediately and with unreserved enthusiasm to help their brothers. And I had changed it to campesinas because here are young women in the village of Monte Carmelo. As I was a couple of months into our stay, I would notice every day the young people in their white jackets coming out of the doors of their houses, or coming in a taxi, which was really a pickup truck, up the mountain from the neighboring towns. And they were going to work and going to school to study Medicina Integral Comunitaria, MEIC, comprehensive community medicine. Except comprehensive doesn't quite translate integral, because integral is also the word in Spanish for whole, as in pan integral, whole bread, or a whole person, developing the whole person. And this medical program is designed for the whole community, for preventive care, for primary care, going up in the system to the other parts of Barrio Adentro, but also to develop the whole doctor, the whole person, in dealing with community issues as well as health issues. It's an intensive 6-year program. People come from all walks of life to enter this. Let's say Mariela on the left just graduated from high school and she started the program. The 3 women in the middle all have young children. They've gone back to the educational missions set up by the Chavez government to finish their high school degrees. Then they entered the medical program. And Karen from Peru is the person on the right. She could not get into the Latin American School of Medicine in Havana because they have a tremendous waiting list to get in from all over Latin America. So she was offered the chance to study in Venezuela alongside these students. Anyway, maybe I'll mention right here, this really struck me as amazing, that my neighbors were going to medical school. And they were going to medical school in their own communities. They were not traveling to Barquisimeto, the city of a million, a couple hours away, or to Caracas. The medical school was coming to them. They were being taught by the Cuban doctors in Venezuela, and they were being taught in 2 ways. Every morning, they spent 4 hours accompanying the Cuban doctors in the primary care clinics or in the diagnostic clinics for about 4 hours. Every afternoon, they all traveled to a common spot in the neighboring big town where 65 of them took classes, formal classes in medical sciences. These classes were taught by Cuban doctors, 2/3 of whom had returned to school for crash courses in how to teach the new curriculum. The curriculum is very similar to that used at ALAM in Cuba and the Cuban medical schools. It features things like human morphophysiology, which is a merger of the medical sciences like anatomy and genetics and physiology, are put together so that lessons revolve, bringing in all these elements at one time in each lesson and progressing over a 2-year period of the first 2 years. Then there's a similar course begun in the 2nd year in clinical studies. What they also have, technologically interesting, is there are CDs available for every lesson of every class in the curriculum. That is every day of every lesson. And these CDs are used by the professors, and I went to class. They invited me to go, and I went to first year class because I would have been lost anywhere else, and probably was lost a little bit there. But in the classes I went to, the professors used these CDs about 25 or 30% of the time, and then they gave their lectures who were quite compelling. I found them very interesting. And then the students had copies of these CDs to take home. So they had the CD about this class. It had more reference material on it for them to refer to. And most did not have computers at that time, but many had DVD players in their homes or in the homes of friends. And so students I knew would gather in groups in the evenings. Part of their evening study would be going over a CD and reviewing it with fellow students. When they reached the third year, beginning of the third year of the medical program, they were all given free laptop computers. So, because most did not have home computers at that time. One thing I meant to mention is it's a 6-year medical study program, but there is a 7th pre-medical year to get everyone up to speed on the sciences they should have. And so the commitment is incredible. And most of these people cannot necessarily give up 7 years of their life, even though the education is free. So the government provides a monthly stipend for them. It's not a big stipend, but in a rural family or a poor city family, it's enough to help the family pay the bills. So also in that pre-medical year, it seems that perhaps 30% of the people drop out, or at least at that time. Maybe it's less now, but that was a way of winnowing out those who maybe weren't going to be serious about the incredible commitment they had to make. This is another neighbor hauling in the coffee harvest, but that was just on Christmas vacation because he too was a medical student, 2nd year. He's helping take a family history outside the consulting office in our little village. This is Edison on the left. He again was a young guy, straight out of high school. And Antonio, who was in his early 30s, he worked at a variety of things before starting the medical program. And that happens to be the cover of Revolutionary Doctors, the Turkish edition that just came out this month in Istanbul. Now on the right here is Dr. Barbara. She was one of the doctors who was kind enough to let me come into her consulting office almost whenever I wanted to, and they just sat me in the corner and let me watch what took place as they interviewed people and checked children out, etc. And she had, I think this was her 5th international medical mission. She'd been in Ethiopia, in Yemen, in Haiti, I forget the 4th. But she was one of these people who was really committed to this idea of spreading a new kind of healthcare around the world. What she always insisted, and Dr. Tomasa, who was the doctor in my little village of Monte Carmelo, she just kept insisting to her students, you can't ask too many questions. Anytime you have a question about anything we're doing or anything you see, ask it. And that's how we're going to learn. I asked her one day, you know, this is pretty tough, working all morning and then going to classes in the afternoon. Do you ever find students aren't keeping up? You know, maybe they're not keeping up with the studies the way you'd like. And she said, on the contrary, I compare it to Cuba, And in Cuba, students do a fair amount of work also in public health settings, but not to the extent I've described here, not like every morning, every day of the week. And she said, I think it really stimulates them. They get so curious and so excited about what they're seeing in patients and the community that I think by the time that they're in their third year, they're further advanced by about a year than their Cuban counterparts. So that was interesting. Not everyone working in Barrio Adentro is Cuban. This is Dr. Edita. She lived in the nearby large town of Sonari. She'd gotten her training as a pediatrician from the existing medical schools. There are some pretty good established medical schools in Caracas and other big cities that have been turning out doctors for the traditional medical system, which isn't so much different than ours, I suppose. I mean, it's oriented towards private care. People coming out of training mostly want to get high-income professions. Even though they don't have to pay off medical school loans, like in this country, their medical education is also pretty much free. But Dr. Edita had always wanted to do community health care of some kind, and she jumped at the chance to do a residency alongside the Cuban doctors, and now is a full-fledged member of Barrio Adentro. So if there are approximately 11,000 to 12,000 doctors working right now in Barrio Adentro, there's another 2,000 to 3,000, perhaps 4,000 by now, Venezuelans working with them who came out of the old medical system, either as older graduates like Edita or new graduates, people graduating from the old medical program but wanting to do their first medical practice by joining Barrio Adentro. These politically conscious students getting out of the traditional schools. Barrio Adentro has already had some significant impact on health in Venezuela, with infant mortality being the big winner here, because almost everyone's getting prenatal care and has access to that. Now, our particular location, we lived on a mountaintop about 20 minutes from a large town. Most people didn't have cars and Jeeps, but we could get a ride in a pickup truck, etc. But other people live out in the Yacambú Valley, with those very deep valleys I showed you in the beginning slides. They may be 4 hours from a family clinic. So there are medical teams that go there in Jeeps, especially during the rainy season on really muddy roads, to, again, make sure that they can see pregnant women, etc. And as long as we were talking about infant mortality, I thought I would mention that Cuba's infant mortality is lower than that in the United States. Again, it's not because of high-tech medicine. Although Cuba has high-tech medicine, it can't necessarily deliver it everywhere on the island. But the main thing is prenatal care and the idea that everyone has access to good physicians, good nurses, etc. Speaking of nurses, I titled this book Revolutionary Doctors, partly because Che had written about revolutionary medicine. He was a revolutionary doctor, and he said, you can't be a revolutionary doctor without having a revolution. You could be a very good doctor, you could be a humanitarian doctor, you could do wonderful things, but to change a health system in this huge a way, you needed a revolution. So I felt a little guilty of not making the title something like revolutionary doctors, nurses, rehab specialists, etc. especially my brother was a psychiatric nurse, and my father was a physician, a socialist who grew up in Milwaukee when it was a socialist city. But I had to throw that in about nurses. I kind of feel bad that it just says doctors in the title. Again, the mortality of children, big change for children under 5. Note the difference in Cuba and the US in the last, say, 14 years. Cuba's made a big change in its mortality rates. The US, a real small change. And so the Cuba is doing better than we are in that regard. And again, because children keep being seen by physicians, and mothers, family know that they can take a children to a hospital or a doctor at any time. So here are some figures about the current time. 32,000 health professionals working in Venezuela. Those are some of the rough numbers. About 90% of Venezuelans have taken advantage of Barrio Adentro. It tends to be located in poor working class neighborhoods and rural communities, but any Venezuelan can take advantage of it. So, in fact, in the hometown of Capriles, who just ran for president against Chavez a few years ago, when he was governor of the state, he tried to evict the Cuban doctors from a large house they shared to serve Barrio Adentro in his hometown. Well, that hometown was mostly a well-to-do town, but it did have some poor barrios and Barrio Adentro doctors. Well, there was a huge protest in that town, and they stopped the eviction process. And one reason why was lots of middle-class people were going to Barrio Adentro, and they were mad that their free medical care might get interrupted. So, again, I've mentioned Mercal. I didn't mention the level of university education, tripled since Chavez has been president. And now we mention, how did Venezuela pay for this? Well, one, the economy grew. Again, contrary to articles you might read in The Economist or other American English publications, Venezuela's economy has done very well under Chavez. They had 2 years of recession when world oil prices fell. And there's been a huge increase in gross domestic spending that goes to social needs. Now, of course, that happened because the government, Chavez did not nationalize the oil business in Venezuela. That had been done back in the 70s. But over a period of years, the high management, the top managers, kind of in cahoots with the international oil companies like Shell and Exxon, were draining off most of the revenues and just giving a portion to the government. Now under Chavez, the government has captured all those revenues to itself, and world oil prices have gone up. So they have the money. But Venezuela is not a rich country. I mean, it sounds rich because it has all this oil, right? But it's a medium income country. That means it's a country of, say, $12,000 to $15,000 per capita income. In the US, it's in the high 40,000 somewhere, 45,000, 48,000 per capita. Yet they are able to be delivering this expansive health care to their population, and they're lowering inequality in the country at the same time. This is just the Gini coefficient numbers for inequality have dropped sharply in Venezuela. It's an international standard. The lower the number, the more equal your country, at the same time as our number keeps going up and up. I couldn't help throwing this in. And our money is going not just to the top 1%, but to the top 1/100th of 1%, because it's capital, and it's capital in the health. You know, we have private health corporations, we have private pharmaceutical corporations, we have private insurance companies that are all taking a large skimming off the top and delivering very high profits to the owners of shares in those corporations. One last thing, there's something that Cuba has called the battle of ideas ever since the 1990s, and Venezuela echoes that theme, and so does Bolivia and other countries in South America, that they're engaged in a battle against the capitalist world in terms of redefining the values that are most important in human life. And this is the slogan inside the halls of the Latin American School of Medicine in Cuba. It speaks to one of Che's most lovely sayings, I think. This is revolutionary doctors coming out in Spanish just now in Cuba. And the stethoscope with the Cuban flag and the Venezuelan flag together is approaching the dawn. That's the design of the cover. The dawn is ALBA, the new organization of Latin American countries trying to have their own independence in setting up the social and economic structures of their own, not dominated by us. And finally, the first woman that I showed in the show, Frances, is a student at the Latin American School of Medicine. Her parents are Nigerian, but she comes from the Bronx. And her pastor told her about how to study at ALOM, and she is a current student. These three are from New York City, Cleveland, and PHSA on the left is from the National Football League. He played linebacker for 4 years before injuring himself, but he'd always wanted to be a doctor too. He would be one of the more unusual students at ALOM. And just finishing, this is a little town in rural Cuba. Medical personnel just having a friendly chat with people on their way to work. It kind of illustrates the integration of Cuban medical people, doctors, nurses, into the whole population. They are very highly respected, but as you probably know, they're not paid more than anybody else. They live at the same standard of living, more or less. And since we mentioned the Cuban Five, this was just a little decoration somebody had put up in their corner of their yard about the Cuban Five, saying they will return. And of course, what's Cuba without dancing and music? And I'll leave you with that thought from President Chavez in Venezuela, because I think it epitomizes how the health system is changing and the whole society, the aims of the whole society. Thank you.
Thank you, Steve, for a great lecture. We now have a few minutes for question and answer session, about 30 minutes. The microphone is over to the right for members of the audience, so you can line up there if you'd like. We'd like you to keep comments and questions to about a minute or two. We'll operate that on the honor system, but I'll just let you know if you go over. Steve is available. I believe Dr. Orris could answer questions as well if you'd like to return to the stage.
Does this mic come out of here? I don't know.
I don't think so.
It doesn't.
It doesn't? Well, we'll shout or something. Or you can shout. Yeah.
Yeah, I'm going to start with a question. I work in disability rights, and one of the things we say is nothing about us without us. We people with disabilities need to represent, and it's kind of like Hugo's quote there about people so they can fight for themselves. But did you see any people with severe disability studying in the medical program in Cuba or in Venezuela? I think that would be important if you were really going to involve people with disabilities.
You know, I don't think I did, but I would think that there probably are people. I think perhaps, you know, my limited range of meeting people never led me to meet somebody with a severe disability. One of the students I met wasn't a disability. He was 75 years old. He was the oldest student in the area. So I think it's definitely inclusionary, and so I would suspect people are, sorry I can't tell you more than that.
Hi, thank you for the talk and for coming to Chicago. And I've also read your book. I very much enjoyed it. I actually went to Cuba this summer with the Venceremos Brigade in July, and you talked about Che Guevara a lot. And I actually visited his mausoleum, and when I was there, we saw a whole bunch of South African medical students who had been trained in Cuba having a graduation ceremony right at the foot of Che Guevara's statue. So it was very, very moving to see his living legacy, you know, right there where he was buried. I guess my question would be is, you talked a bit about the Latin American School of Medicine in Cuba. I heard that Venezuela plans to build an equivalent school, similar size and scope and mission. Do you know anything, any of the details of this project? Yeah.
I actually don't, and perhaps Rixio is here from the consulate could answer it. As I told you, there were students from elsewhere in Latin America coming to study alongside the Venezuelan students. Did I ever tell you how many students were studying in Medicina Integral Comunitaria? 25,000 students. That's what blew me away and probably led to this book. It wasn't just the small number in my village and my state. There are 25,000 people, but also in that year that I was there, 1,000 had come from other countries to study alongside them. And I think I've heard things about Latin American School of Medicine evolving in Venezuela. Rixio, can you say anything to that?
Yeah, there's an extensive project, not only to build a school, but to build complexes for specialized medicine. In fact, near my neighborhood, there is the biggest Latin American complex for cardiology for kids. I don't know exactly what the medical term is for the whole complex, but they what they did is the site where the Pope was for a long time. The Pope came to visit 10 years ago, and they didn't know what to do with the site, so they finally, I guess, started construction there. I was asking about this when I lived in Venezuela, and in fact, a couple years later, after I was here, I got my post. We got a big announcement in the paper, the mission paper that we get, saying that this school, this complex was inaugurated along with the projects to start the ELAM in Venezuela. And the reason why they want to do that is that a lot of the students in South America will actually have access to a bigger complex. This is a very ambitious project. I'm not sure if it's finished yet, but it is definitely in the works. So if you guys like more information, you can email us at the consulate. The email is BEM, the first three letters of Venezuela, .chicago@gmail.com. We'll even send you links. So, thank you.
Great lecture, and I'm really looking forward to reading your book.
have you seen anything, either Steve or Peter, have you seen anything in the United States that you think is, as far as actual healthcare or healthcare programs, that you think is going in the direction that you've seen in Cuba and Venezuela?
Well, I probably ought to leave that to Peter. I haven't seen anything like that, and I have met people who've had aspirations in that direction for a long time. I mean, I have friends who are retired pediatricians who went to rural areas 30 or 40 years ago, hoping that other doctors would join with them, and they would slowly build up a rural connected system in Maine and Vermont. And they ended up having very successful small practices. That is, a group of 5 or 6 doctors that really took preventive care seriously, that really reached out to the community in ways you don't always expect every physician to do. But I don't know if many experiments where that spread. I know there's a community health program in the Roxbury area of Boston that has some pretty good things going on, but the scale is limited, I think, by the overall system we have of educating, financing, private profit often above public responsibility in terms of priority. But maybe Peter can answer it better than me.
Hi there. Oops. Make this microphone a little bit shorter so I can reach it. Hi, my name is Joy. I work here in Chicago as a sex educator and volunteer as a birth doula. And so I'm constantly thinking about issues of reproductive and birth justice. And I was really impressed by the decreases in infant mortality, and when you spoke about the improvements in maternal and child health care, that got me really interested in the ways that this kind of work could connect to the work that I do here in Chicago. So I was wondering if you could speak a little bit more in depth about the maternal health care that you were able to learn about in Venezuela, especially any sort of community birth work or midwifery models that could be replicated.
Well, I wish I knew more. I don't know very much about midwifery in Venezuela or how it's been included within the medical system. There has been an effort by barrio dentro doctors, and Cuban doctors have done this abroad in other countries where they've worked, to draw people in from traditional medicine with traditional cures and herbal cures and that sort of thing. But in terms of midwifery specifically, I don't know. What Venezuela has done, and I'm blanking on the proper name of the program, or maybe more than one program, it's instituted 2 or 3 very important programs for poor mothers to make sure not only that they have the prenatal care, but that they have special access to additional food, any other resources they need to make sure that their baby is going to be healthy and strong. And then that follows over to preschool. I mean, there's now preschool, free preschool for most Venezuelan children. And so again, that relieves the mother of some of her burden and can devote more time to the baby. So, but I'm sorry, I can't give you more specifics on maternal care itself. Just that it is being emphasized that it's important, for sure.
I got a short question actually. When Chavez got into office, when Chavez got into office, there was deficiencies in a lot of different areas of what we call social debt, and the social debt needed to be repaid. And so the fastest way that we could actually devise something that would go over the bureaucracy of the country was to create this program such as Barrio Elena. Now the program that she's talking about was actually 2 different programs. There's Madres del Barrio, and then the other program, I don't remember the name of it, but I actually can give you links to this too. And these are very aggressive programs to pretty much identify what the problem is, then use very aggressive methods when it comes to not only injecting money into the project, but developing the project. And this is the reason why the Cuban doctors actually, the government as well, we have deficiency in our doctors because we didn't have the amount of doctors that we needed for the population and their health issues. And also, a lot of the doctors came from the traditional institutions, and they didn't want to go up to the barriers. They didn't want to go up and visit people. They didn't want to implement this system because the system is not a profit system. So this is only an example, but there's 4 different missions, that's what we call them, that actually are very aggressive as they tackling these issues and then rooting themselves and having various spaces up to an advanced level. And like Steve said, there is also a level where not only they take care of the mother, but they take care of the kid up to a certain period when he's actually able to go to high school or to go to a kindergarten. But it's kind of through phases, and those phases have been developing themselves based on the necessity and based on how the program worked the first time. For example, Barrio Adentro has now a Barrio Adentro 2, which is the second phase of Barrio Adentro, which is a more specialized medicine, and it's a different kind. It kind of spawned off not the Cuban model itself, but the Venezuelan model, and we're culturally different. So therefore, we also are able to develop our own system based on our country. We're able to start with the Cubans, but we continue to decide to move. But again, feel free to email me. I got tons of information, hours and hours of plays and we have like about 200 DVD videos for free that you guys can request, and you can come and pick it up at our office or the Larry Opera building, 19th floor, and they're all free, like I said, so feel free.
Margaret Davis, and I'm with the Chicago chapter, National Black Nurses Association, and thank you for adding nurses to the title, because we feel that nurses, because of the largest numbers, that we really have a great influence on social justice and health care. But I went to the Racism Conference in Durban, South Africa, and at that meeting, Fidel Castro, he spoke for 2 hours, and he talked about the social justice that the doctors that he was sending all over the country was having. However, he didn't quantify how many, but if there's 25,000 students in Venezuela, I just was wondering, did you have a number on the Cuban doctors? I know that we've sent people from New York, Montgomery, Alabama. I don't know of any students who went from Chicago to be trained. Was there somebody?
There's one right here.
Okay, there's one?
No, I'm not actually from Chicago. I'm from Philadelphia.
Okay.
I think I might be the only person from Philadelphia. I'm very lonely. But I came to Chicago because it's similar to Philadelphia. But we have one graduate from 2010 who's working actually at Rondell Christian.
Okay.
Her husband, who's from Mali, that followed her here. And there are 2 that just graduated and are applying for residency that are from Chicago.
Okay. So that's good, and we really need to know the pipeline by which more can get into the system. And they seem to be getting into a very social justice type of position, who has a relationship with Cuba to funnel students into that program. But the last thing I want to talk about is infant mortality. In Cuban systems, we have seen much work on identifying high-risk women. This is where infant mortality comes in. High-risk women produce small babies, bad babies, and in Cuba, these women in their last trimester are put up in like a home where and just really catered to with love and affection and good nutrition and just everything. And I feel that that has a great impact on reducing infant mortality.
Thank you. Thank you. By the way, I sometimes mention in terms of how many doctors are being trained, with the 25,000, perhaps 30,000 being trained in Venezuela. In Cuba, there's about 28,000 Cubans going to medical school, and ALOM has expanded to now include some other programs around Cuba that educate foreign students. So there are about 20,000 foreign students being educated in Cuba. That means over 70,000 doctors are being educated by two small countries with about 40 million people and about 1/50th the economic resources of the United States. The last time I did a rough count of the number of students in medical school in the United States, there were about 68,000 students in the United States. So they're producing more than our country, which means we don't have enough doctors produced in this country. And where do we get them from? Many come from poor countries who are educating their doctors with their scarce resources, and then they come here for whatever reason. They want to practice higher quality medicine or they want more money. But they are the ones filling, for instance, the family medicine residencies in this country. I think more than 50% of them now are being filled by doctors from other countries because very few U.S. students are going into family medicine anymore, either because of level of interest or maybe it can't pay off their huge amounts of student loans. So just a related comment. Yes, next question.
I had a chance to go to Cuba 20 years ago during the start of what they called the special period, when they had just lost most of their trade with the Soviet bloc, and the United States was bearing down hard. So at that time they had some real critical shortages of drugs, especially other technologies, and were rationing what they had. For instance, they would keep the antihypertensives for people with like severe high blood pressure would get medicine. If you came in with mild high blood pressure, you would get manzanilla, chamomile tea, and some advice about your diet. They were saying at the time they felt that it was really improving their medical care, that it was, focusing more on conditions of life, making it more integral. I thought at the time they were trying to put a brave face on a bad situation, but 20 more years of experience with the American healthcare system has kind of convinced me they might be right about some of this. I was wondering how it stands now, and like if there are, drugs and technologies that they don't have that they feel they need, and if there are some that they feel that they are doing just dandy without.
Yeah, I think I'll let Peter do it. I'll make a short comment, though. From my understanding, there's still shortages of key drugs they would love to get at reduced prices directly from the United States, but they have to go our circuitous route to get the drug or the equipment from another country. So that is hurting them to some extent. The one thing about the special period, I think with the exception of 1 or 2 years, through the 1990s, that the health indicators statistically kept advancing because Cuba decided it would, despite the economic problems, it would not hold back anything it could possibly give to the medical system and the number of doctors it was continuing to educate. So I'll let Peter go on.
Just briefly, your public health folks and we're in a public health school. So the special period is a good example of a public health approach to poverty and to shortages of foodstuffs, etc., and shortages of energy. What they did was they imported from China millions of bicycles. So everybody was riding bicycles. They were also in these horribly large buses, they're called camels, but the bicycles, they will zero in on the bicycles for a moment. They also distributed the foodstuffs that were available to the population. So within, this is a country in which at that period of time, the adult population got fitter, riding bicycles, lost weight, because this was just at a period of time that Cubans were beginning to have a problem with obesity as well. So the adult population and the young adult population loses weight, gets fitter, and sure enough, the cardiovascular problems go down, the hypertension goes down, and a variety of other things. That's not to say that the shortages of medicines at that time did not have an impact on individuals that needed it, and it was a major problem. That problem is alleviated. The Cubans make their own medicines, and in fact, the Cubans decided that they were going to get into the biotechnology era because they could also compete in that aspect. The U.S. biotechnology company in general was capitalized by $1 million or so at that period of time, developing one or another new drugs. The Cubans put 15, 20 million together and put it into developing the biotechnology stuff. So they have a number of drugs and vaccinations and other things that are not available in this country and other areas, and they are selling them abroad, except for the fact that the U.S. Is competing with them and is telling any numbers of countries, if you buy their materials, we're not going to deal with you for the other drugs, etc. So there's a major conflict going on economically for their attempts to utilize what they have developed in biotechnology around the world. So yes, public health does work, and it does work on the general population.
Thank you very much for your very informative presentations. I just wanted to mention that partly inspired by the healthcare system of Cuba and now Venezuela, that there's a very active movement here in the U.S. for single payer, to have a single payer government paid healthcare program open to everyone. I don't know the website of it. There's an active chapter here in Chicago. Dr. Quentin Young and others participate in that. But I'm sure if you look it up on the internet, you'll be able to find that and join in to that movement, as well as the movement for the people to become deciders. Participatory democracy all the way. Thank you.
Dr. Sheets, that sounds like an intro for you.
IL Single Payer Coalition.org.
Do I need a mic? No, I don't think so. The brother who just raised single payer kind of did what I was going to do. I graduated from school here down the street at Occupational Therapy School, and I'm indebted to a professor of mine who actually told me what single payer was, and who opened my eyes as to the main obstacle in providing health care for everyone in this country, and that's the insurance industry. And it just changed how I thought of what I'm doing as a therapist and what I need to do as a human being. And you know, I feel like activism, in addition to providing health care, is so critical. And I just wonder, you know, like the situation you described in Venezuela and Cuba, it's like they actually care about people's well-being and health outcomes. Whereas in this country, it's clear. The motive is about how we can get more people to buy insurance. You know, if they get better, like, whatever, you know what I'm saying? So I guess my question is, in your book, do you at all talk about, I mean, it's really inspiring what Venezuela and Cuba are doing. Do you at all talk about what we need to do politically in this country to have a system that can actually pave the way for this kind of healthcare to be possible?
Well, I think we need a revolution. But I didn't say that in the book. Because I guess I don't think that's happening next week or next year. But those who work with single payer, I've included numbers. I told you I wrote chapters in previous books on the U.S. Health system, and I've included numbers, and I can't remember them accurately, but I think something like 18 to 20% of health dollars get eaten up by insurance companies in one way or another, or administrative costs, 35%, and they drive doctors and nurses and medical personnel nuts because they're dealing with who knows how many hundreds of health plans and insurance companies you might have to deal with even in a small office, let alone a metropolitan hospital. Just think of all the hours of physicians' time and nurses' time and people, receptionists, whoever's keeping the records. It's extraordinary. And then compare it with countries where it's just free, or with this country where it's Medicare, or veterans, or the Canadian system, where the whatever, you know, the 35% or whatever, the administrative charges percentage, I think, in Canada is something like 2 or 3% to administer their medical system. Maybe not quite that low, but it's so much lower. What a difference could be made. You have anything to add? Okay.
All right, my name is Ashley Dyer, and I'm an alum of UIC SPH, and I think as a person who has finished her Master's of Public Health, I still believe in a revolution, so maybe it's coming down the line. But I think something that you spoke to that I'd like you to speak a little more on is, you know, not only revolutionary doctors, because I think people are important, revolutionary doctors, nurses, occupational health therapists, but revolutionary health systems. And something that really excited me about your presentation was when we walked into that kitchen with those women who were once volunteers but now being paid to serve the community in which they lived. But not only were they serving, you know, nutritious food, but then now they have a job. So I was wondering if you could kind of speak to maybe lay community health workers, or even kind of re-envisioning outside of, you know, the medical world in terms of doctors and nurses, and speak to how that's kind of playing out in Cuba or Venezuela, or whether or not you think it's becoming a more formalized part of this community health system.
Well, that's an interesting one. Let's see. I think you're absolutely right that health and community and a better life really all go together. They should encompass all communities and find a place where people have meaningful work serving their community. And what we're talking about with the women serving the meals and the people organizing the health committees in every neighborhood, or the committees in defense of the revolution in every Cuban neighborhood, is that people feel they have a role in promoting the welfare of their community, a very direct role. And I mean, there may be social workers to go talk to too, but they feel the freedom and the obligation to take part. And one thing I have a little subchapter heading called Practicing Medicine, Practicing Revolution, is that people are creating themselves as revolutionaries, that not just as medical practitioners or whatever else they might be doing, but taking on a role of, you know, a large role in the society to look after everybody with my fellow citizen and change that society. Health committee, women members of health committees in Venezuela have been very instrumental in bringing attention to gender violence in their communities. And they will sometimes get a group together and go confront somebody who might be beating his wife and say, you know, the community knows about you. They're not threatening him, you know, necessarily to kill him or anything. They're just saying, you know, we don't like what you're doing. The community doesn't like what you're doing. Now, it might not succeed necessarily, but it's a positive community reaction to a real public health threat. I mean, that's a public health threat. So, in a way, how that translates to this country, I'm not sure, except that maybe people going into public health should be looking at those links with whatever is growing within a community that can build relations that are really interested in positive outcomes in everybody's lives.
we have another round of applause for our guests.
Thank you.
One last thank you to our co-sponsors, to Dr. Orris and Steve Brower. Most importantly, thank you to our wonderful audience for spending your evening with us. Before we go, I do have one quick announcement. As was mentioned earlier, on the back of your flyer, you'll see our next event, which will cover mass incarceration, the drug war, and the prison industrial complex. With Michelle Alexander's book, The New Jim Crow, and Eugene Jarecki's film, The House I Live In, both reaching large audiences, there's much energy and conversation about the negative impacts of mass incarceration on individuals, families, communities, and our society. So next Monday night, we'll meet for a discussion of how our system of mass incarceration manifests as a social determinant of health, and how the public health community can respond to this abusive system. To receive the articles and join our discussion, you can email us at rph.uic@gmail.com. This concludes our program. We have some light food and drinks down the hall in the lounge inside the front door. Hope to see you there. Have a great night.